Combination therapy with biologic disease-modifying antirheumatic drugs, bDMARDs, is a treatment strategy used in managing certain rheumatologic conditions, especially when monotherapy is insufficient. Combining biologic DMARDs with other DMARDs, such as methotrexate or conventional synthetic DMARDs, is more common as it has been shown to enhance efficacy, prevent disease progression, and reduce the development of antibodies against the biologic agents. However, the use of two or more biologic DMARDs simultaneously, biologic-biologic combination therapy, is generally not recommended due to the increased risk of severe infections, adverse events, and high costs. Here are some key points regarding combination therapy involving biologics. Common combinations, biologic plus methotrexate. This is the most frequently used combination. For example, TNF inhibitors like infliximab adalimumab are often used with methotrexate to reduce immunogenicity and enhance efficacy. Biologic plus corticosteroids. Short-term corticosteroids may be combined with biologics in patients with high disease activity for more rapid symptom relief. Risks of biologic-biologic combination. Infections. Increased risk of serious infections like tuberculosis, bacterial sepsis, and opportunistic infections. Adverse events. Potential for more frequent or severe adverse reactions, including liver and kidney problems, as well as immune-related issues. Lack of evidence. There is limited high-quality evidence to support combining two biologics in practice, and the available studies have not shown a significant advantage over monotherapy with increased risk of complications. Emerging concepts. Sequential use of biologics. When one biologic fails to control the disease, switching to a different class of biologic is common. Dual targeting. Experimental strategies targeting different pathways, such as combining a TNF inhibitor with an IL-17 inhibitor, are under investigation but are not widely adopted due to safety concerns. Would you like more details on specific conditions where combination therapy is used, or the risks and benefits of specific biologics? The combination of biologic DMARDs, biologics, is a complex and evolving area in the treatment of rheumatologic diseases, particularly rheumatoid arthritis, ankylosing spondylitis, psoriatic arthritis, and other inflammatory conditions. The practice of combining biologic DMARDs, biologic-biologic combination, is generally avoided due to the associated risks, though some potential benefits are considered under specific conditions. Here is a breakdown of the risk-benefit balance for biologic DMARD combinations. Potential benefits. 1. Enhanced efficacy. Theoretically, combining biologics that target different inflammatory pathways, e.g., TNF inhibitors with IL-6 inhibitors or IL-17 inhibitors, could result in better disease control for patients with refractory disease. This strategy could help in patients who have not responded adequately to a single biologic, aiming to reduce inflammation more effectively and prevent joint damage. Number 2. Reduce dependence on steroids. For patients with severe disease, biologic combinations could potentially allow for reduced reliance on corticosteroids or other immunosuppressive drugs, which have long-term side effects. Significant risks. 1. Increased risk of infections. The most substantial risk with biologic combinations is an increased susceptibility to infections. Both biologics suppress immune function, which can lead to serious infections, including tuberculosis, bacterial infections, and opportunistic infections like fungal or viral infections. Data from studies combining TNF inhibitors with other biologics, e.g., IL-1, IL-6 inhibitors, suggest a high incidence of infections requiring hospitalization. 2. Risk of malignancies. Although the risk is not conclusively proven, long-term suppression of the immune system from dual biologic therapy may increase the risk of malignancies, including lymphoma. 3. Adverse reactions and toxicity. Increased occurrence of drug-related adverse effects, such as liver toxicity, blood dyscrasias, and cardiovascular complications, has been reported when biologics are used in combination. Combining biologics can also increase the risk of infusion or injection site reactions. 4. Autoimmune reactions. Paradoxical immune activation leading to autoimmune conditions, such as lupus-like syndromes, psoriasis, or inflammatory bowel disease, may occur more frequently with combination biologic therapy. 5. Lack of supporting evidence. Few large-scale clinical trials have shown that the benefits of combining biologics outweigh the risks. Most studies recommend monotherapy or biologic with conventional DMARD combinations over dual biologic use. Risk mitigation strategies. Close monitoring. Patients on biologic combinations must be monitored closely for infections, liver function, and blood counts. Infection prevention. Prophylactic measures like vaccinations, e.g. pneumococcal, influenza, and zoster vaccines, and TB screening should be performed before initiating combination therapy. Patient selection. Combination biologic therapy, if considered, should be limited to patients with severe refractory disease who have failed multiple monotherapy biologic treatments and after carefully weighing the risks. Current consensus and clinical practice. Combination with conventional DMARDs. The preferred approach remains combining biologics with conventional DMARDs, like methotrexate or leflunomide, rather than combining two biologics. This strategy balances efficacy while minimizing adverse effects. Off-label or experimental use. Biologic combinations are mostly reserved for clinical trials or experimental scenarios and are not a standard of care due to the heightened risk of adverse outcomes. Conclusion. The risks associated with combining biologic DMARDs, particularly serious infections and potential autoimmune or malignancy risks, generally outweigh the benefits. As a result, dual biologic therapy is not recommended in routine practice, and safer alternatives, e.g. biologic plus conventional DMARD, are favored. Combination biologic therapy should only be considered in highly selective cases where patients have severe disease resistant to all other treatment options. If you're interested, I can provide details on specific biologics and their interactions, or discuss the ongoing research in this area. The use of biologic DMARDs, bDMARDs, in combination has been a topic of research due to the need for better treatment strategies in patients with refractory autoimmune diseases. However, most studies discourage this practice due to increased risks, particularly infections and adverse events, while others explore the potential benefits in very select patient populations. Here are high-impact studies that have influenced clinical guidelines and perspectives on the use of combination biologic therapy. 1. Dancer Study, 2005, abatacept plus biologics. Title, abatacept in patients with rheumatoid arthritis receiving background biologics. Design, randomized and placebo-controlled. Key findings. Patients receiving abatacept, a CTLA-4 Ig, in combination with other biologics, TNF inhibitors, had increased rates of serious infections. The study had no significant improvement in efficacy compared to monotherapy. This trial highlighted the risk of combining biologics, particularly TNF inhibitors, due to infection risks. Conclusion. It discouraged the use of abatacept in combination with other biologics. Source: Winblatt M.E. et al. Arthritis Room, 2005. Tocilizumab and TNF inhibitor combination study, 2010. Tocilizumab plus TNF inhibitors. Title: Combination therapy with tocilizumab and TNF inhibitors in rheumatoid arthritis. Design: Open-label pilot study. Key findings: Patients treated with tocilizumab and IL-6 inhibitor plus TNF inhibitors experienced a higher rate of adverse events, particularly infections, without a significant improvement in disease outcomes. This study underscored the danger of overlapping immunosuppressive effects. Conclusion: No added benefit was found, and the safety profile was concerning, leading to recommendations against combination. Sorim et al. And Room Dis, 2010. 3. Rituximab in combination with TNF inhibitors, 2011. Rituximab plus TNF inhibitors. Title: A study of rituximab in combination with TNF inhibitors in patients with rheumatoid arthritis. Design: Phase 2. Key findings: Although rituximab, an anti-CD20 monoclonal antibody, showed potential for efficacy combined with TNF inhibitor, there was a notable increase in serious infections, including pneumonia and opportunistic infections. The trial was halted early due to safety concerns. This study provided clear evidence against combining rituximab with TNF inhibitors in clinical practice guidelines. Source: Cohen S.B. et al., Arthritis Room, 2011. 4. Oral Strategy, 2017, tofacitinib, JAK inhibitor plus biologics. Title: Tofacitinib, Biologic bDMARDs and Methotrexate in Rheumatoid Arthritis. Design: randomized controlled trial, RCT. Key findings: combination of tofacitinib, a Janus kinase JAK inhibitor, with biologic bDMARDs, particularly TNF inhibitors, did not show superior efficacy compared to either agent alone. The study noted an increased risk of serious infections, deep vein thrombosis, DVT, and cardiovascular events. Conclusion: this trial for combining tofacitinib with other biologics is not beneficial and increases risks, leading to discouragement of JAK inhibitors with biologics. Source: Fleischman R. et al., Lancet, 2017. 5. Rabbit study. Say biologic combinations. Title: Biologic combination therapy and risk of serious infections in rheumatoid arthritis. Design: prospective observational study. Key findings: the study examined patients on biologic combination therapy and found a higher rate of serious infections compared to those on monotherapy. This was a large cohort study that provided real-world evidence on the risks of biologic combination therapy. Conclusion: the findings confirmed the safety concerns around biologic combinations, contributing to their avoidance in clinical practice. Source: Strangfeld A. et al. and Romdis, 2017. 6. Siraund T17. Saralumab plus biologics. Title: Saralumab, IL-6 inhibitor in combination with other biologic bDMARDs in rheumatoid arthritis. Design: randomized controlled trial. Key findings: patients receiving saralumab, an IL-6 receptor antagonist in combination with TNF inhibitors, showed no significant efficacy benefit compared to monotherapy. There was a substantial increase in infections and neutropenia, leading to early discontinuation of many patients. Conclusion: this trial strongly discouraged the use of IL-6 inhibitors alongside TNF inhibitors. Source: Genovese MC et al., Arthritis Rheumatoid, 2017. General from these studies: limited efficacy. In most trials, the combination of biologics does not yield significantly better outcomes compared to monotherapy with a biologic bDMARD, especially when combined with conventional bDMARDs like methotrexate. Increased risk of infections. Across studies, the most consistent finding is the markedly increased risk of serious infections, which often outweighs any marginal benefit of enhanced disease control. Adverse events. Combination biologic therapies are associated with higher rates of adverse events, including infusion reactions, neutropenia, liver enzyme elevations, and cardiovascular events. Conclusion: most high-impact studies have discouraged the use of biologic bDMARD combinations due to the heightened risk factors and other adverse effects with limited additional efficacy. Clinical guidelines influenced by these trials generally recommend against biologic combinations, preferring biologic monotherapy or combinations with conventional bDMARDs, e.g. methotrexate. The ongoing focus is on optimizing safer, more effective single-agent or conventional combination therapies. Would you like a deeper dive into any specific study or a particular biologic agent?